Hi, everyone. Welcome back to the podcast. Welcome all new listeners, and welcome back to those who have heard my content in the past. If you want to know about sacroiliac clinical pearls and rehab strategies for the sports PT, you need to tune into this episode. Before I go on to the podcast, what is new? This is a tougher start to this podcast compared to others. For those who've been listening for a while, I'll share some interesting things that are happening in my world and have unraveled over the last 48 hours. Actually, probably 24 to 36. But nonetheless, yeah. So here's what's happening. So I was informed by somebody very special in my family, in my near family, that they are struggling with throat cancer. I've done an episode on that, and that was tough news, and we're still navigating that. That's number one. About a week later, I was informed that an extended family member of ours is now battling prostate cancer. And then I get news last night that another big influential person in my life is now struggling with the potential lung cancer. Um, and on top of that, my daughter yesterday was riding her bike, and she's been without training wheels for about a month to 2 months now. She just recently knocked out her two front teeth, like permanently, until the new teeth grow in, which can be up to 2 years. So yesterday was a wild ride, and so I'll give you some lessons learned and where I'm at mentally with all this because I get this news within the last 72 hours, and that's rough, right? Like none of us can argue that that's a tough scenario to be in, and the question is, how do you manage that? What do you do? How do you put yourself in a good place? How do you continue and push on? With all those three things, the thing I can tell you right now that I'm making the most effort with is just to be present with my family, just to be present with my kids, just to be present with my team and my staff, and literally just I'm in the office more than ever. I'm just literally hanging out with everybody, touching base. How's life? What's new with you? How's your family? Because I know I'm not the only one going through that, and I'm sure some of you are. But I just had a conversation with my wife yesterday, thinking like, how does this all like happen in the holidays? Like I know it happens throughout the year, but for some reason, there's a lot of times where these things kind of like they just mesh together, and the holidays seem to be a time where these things just are we're just informed, and maybe people are more sick, they're in the hospital, they get checkups and workups. Nonetheless, yeah. So those are my four things: throat cancer, prostate cancer, lung cancer, and my daughter's two front teeth. So it's been quite the 48 hours. All I can do is be present with everyone and enjoy the ride. So, all right, life is good. Otherwise, can't complain, and I'm really excited about this podcast episode. So let's go on to this. All right. So why are we doing this episode? This is off of a recent patient case, so I wanted to be able to share it with everybody, and I think that. There's sacroiliac joint pain is not easy to manage, and sometimes it is, but when you have chronic, recurrent, stubborn, with a very active individual, this can be a very, very tough ride. And I want to share today what I've learned in 15 years of working with athletes from acute sacroiliac pain to chronic to stubborn to some of the most complex cases that I've seen, numerous injections, even surgery. And I want to share those cases today so that way you don't have to struggle as much as I have. I've looked up a lot of research. I have navigated a lot of patient cases. I've been mentored. I'm going to share with you not just the tactical rehab strategy of like, well, manual work, whatever it is. I want to outline what to look for and how long these patient cases can take. So, if you're a sports PT and you want to develop your strength and confidence inside managing SIJ pain, this episode and all this content is going to be absolutely perfect for you. So, let me present a case. If you're inside my Sports PT Academy, some of you mentioned that you enjoyed the patient cases again, and it got you in the mindset of the Kickstarter course that I've done in the past, and I am doing in January. But this is going to be very similar if you've heard my patient cases, and it helps you kind of frame, what you would be doing inside your clinic and how you do it, navigate it just a little differently. So here's the patient case. I'll give you a couple things. This is a 45-year-old male with right PSIS pain, like very localized to the PSIS, and their preferred method of exercise is functional fitness. So everything from body weight to wearing a vest to burpees to weightlifting to doing it all, just functional fitness. They're a very active individual. They exercise 5 days a week. They stand for a living. They stand and drive. And if you split those up, that would be 50-50. It'd be standing 50% of the time and driving 50% of the time. And their occupation is not very laborious. They're literally just standing and driving. And they work out 5 times a week, functional fitness, pretty high intensity, and a lot of weight. And this developed insidiously over the course of 3 or 4 months. And now they are 6 months into their course of care, and they're still struggling with SIJ pain. And I'll give you some other background going into this. So they had X-rays and MRI as well, which showed normal things for a 45-year-old. Annular ligament tears, maybe a disc, minor disc protrusion, small things that didn't align with their symptomology. So when you look at patients and athletes, that's always the struggle, right? You're waiting for an MRI to tell you yes or no. But if it's truly sacroiliac pain, the only reason you're doing a lumbar MRI is to rule that out. Like, is there any referral things that I'm missing in here? And by this time, you've probably done, PAs or slump tests or straight leg raise, anything to rule out the lumbar spine. You've done clinical prediction rules. You've probably done lumbar mobilizations, and you find that nothing is really affecting the PSIS pain coming from the lumbar region. You rule out the hip, you do scour, you do Faber, you do Fader, you do all of the above, and those really don't elicit the symptoms. Now, behind the scenes, last episode I gave you a framework to what are the 3 or 4 things. It was three plus a bonus of what things do you need to look at on the subjective or an initial evaluation to set you up for success so you can create better plans of care. And the first thing I said in there was, what's their phase of healing? So this person's 6 months out from the initial onset. So how does it change your framework? What are you doing? It means that you don't have to attack it so aggressively early on. They're in the remodeling stage, and you're really not going to aggravate a lot because they've probably been through so much in the acute and subacute, which you missed. So now the phase of healing is chronic. Where do they sit on the bell curve? For those who are new to the podcast, to the family, to the community, is the bell curve is essentially the left hand side of the bell curve is inactive people. Those are your bottom 10%. And the top 10% are your pro athletes who exercise too much. And the middle of the road is the 80%. I put myself in that category. We train 5, 6 days a week. We're active, but we know how to control. We don't have to push and pull all the time. We know when to back off, and we have that luxury, that convenience to be able to push and pull without the pressure of a pro athlete. So this person, this 45-year-old case, is in the middle of the road. They're at the middle of the bell curve, and their phase of healing is chronic. Now, what is the third part of this framework was the timeline. What's the timeline? So this person literally just wants to get better as soon as possible. They don't have a competition. They don't have anything that's there. So now you have somebody who is in the chronic stage, who is in the middle of the bell curve, and doesn't have an urgent timeline. Okay, so from a physical therapist standpoint, now that kind of helps you figure out, okay, what do I need to do here? How am I going to manage this case? Another piece that I've added in the past to this framework is, what's their motivation? For a lot of you who work in an ortho clinic, maybe you only have maybe 10, 20% of your total caseload is athletes, and the rest of people are, maybe the bottom 10% of the bell curve. They're not very active. They're not very motivated. It takes you so much work to just even get them to challenge themselves or be consistent with their X or their home exercise program. this person's motivation is very high, so they want to be able to get out, and they've seen multiple providers before. Just to kind of put it in context, they've seen chiropractic, I think they've seen acupuncture, and they've seen massage and other PTs before in the past. So the question is, what do you do with a case that is 6 months old, a very active individual, very motivated, no rush, no timeline, and has seen previous providers? And so for some of you, you're like, well, I know what I would do. I would clamshells. I would do walking banded resisted abduction. I would do single leg RDLs. I would do deadlifts. I mean, let me guess. Like these are all the normal things that you would do. I would do core activation. I would do some type of Shirley Sarman's low ab sequence. Like there's so much to. I would do rotation like bandy, stretchy, like exercises. There's so many layers to this, and so before you go down that rabbit hole of which exercise to choose, let's go through this case, and I'll share some clinical pearls and rehab strategies on how to attack this so you make the best decisions and you make the best corrective exercise decisions, not just in the quantity and the quality, but when to implement them. So let's go through this. I have some notes behind the scenes as well. So um, all right. So we went through the phase of healing, bell curve, their timeline. They're very motivated. All right. So when we go through this, um, when you start talking about treatment and what you're going to do to help this individual, there's two forms of treatment. You have to decide what you're going to do here. What are you going to do immediately to reduce their pain right now, like inside the clinic right now? And then what's the delayed form of treatment? Meaning, we know that if you're a movement PT, you're going to be like, oh, I'm going to change the way their glute turns into external rotation and how their hip flexion controls it, and they don't pull on their psoas and pull them onto lumbar extension, all these other things. Those are delayed things. Those are going to take a while to occur. So minimum 4 weeks, right, just to learn a new process, neuromuscular control. But you have two strategies here. What are you going to do immediately, and what are you going to do for a delayed form of care? So, delayed, we can go down multiple rabbit holes, but let's figure out what we're going to do in the first 4 weeks. How do you plan to reduce this person's pain right now? Not like, okay, well, we're going to change their movement. No, no, no. We know that takes a while. So, what are you doing right now? There's a couple different options. Whether you are a modalities person or not, whatever, that's your preference. But one of the first things you can do right now in the clinic, now you assess this person. Some of you asking, okay, well, what do they look like on assessment? They have an anterior pelvic tilt, right? PSI is a little higher, no structural leg length discrepancy. They wear, regular Nike shoes. They don't wear like boots or sandals or anything. So they have normal footwear. Are they pronated? Yes. Bilaterally, nothing significant. When does the pain come on? Anytime that they stand for prolonged periods of time. So this is an interesting concept because most people, it hurts when they run, right? When you have disassociation or nutation or counter nutation of their pelvis. And so for this individual, it's just prolonged standing. And so when they stand in anterior pelvic tilt, that's when they have all the pain. So they actually prefer to be supine with legs elevated into posterior pelvic tilt. So the lumbar spine is cleared, MRI is cleared, insignificant findings on an X-ray, and their primary pain is when they stand for prolonged periods of time. That is the main concern. And their pain level is 7 out of 10. It's sharp and it can be achy. So what are you going to do right now to reduce their pain? There's a couple different options. One of the first things I like doing to discern where is this primarily coming from, I like doing manual blocking with my hands of like compression testing, distraction testing, just to see what is happening to the pelvis, right? There's so many ways you can go. Is it up slip, down slip? Is it loosey goosey? Is it too stiff? Is it rigid? Is the right side down? Whatever that may be. So one of the best things you can do before you put them on a table is as they're doing forward flexion or extension or side bending rotation, and they are complaining of symptoms, your next goal is, can you apply force or stress before they sit down and you do other testing? to determine if that reduces or increases their pain. That's all you're looking for. You're just looking for a comparable sign. Even if it increases their pain, that's beautiful because now you can change their symptoms. That tells you that you are in the musculoskeletal world when it's reproducible, right? So I'll do squeeze test. So I'll do a squeeze test on the pelvis and standing. So if they have pain with forward flexion, I'll squeeze their pelvis and see if that actually helps. Or I'll do distraction by compressing the ASIS together with the same form of testing, standing, forward bending, whatever that is, or single leg into extension, or bilateral limbs on the ground with going into extension. In another case, you're trying to see where you can reproduce, rotation, all these other things. So once I find a comparable sign, and for this individual, it was compression. They love the compression. So that to me told me, great. So now we have a unstable or some form of a loosey goosey pelvis. Well, that gives me a direction to go through inside my care. So one of the first things we did was we applied a sacroiliac joint brace, and that's like a belt. And for those who don't use that, it is fantastic. Patients love it. It's something super easily to do it. I don't have any financial interest, but the company or the brand that I use is Serola, Serola. They do a fantastic job of had steady outcomes with their Velcro. It doesn't come undone. They're super affordable on Amazon and patients love it. They don't have a I mean, for 40, $50, it's worth it to them because they've been in pain for 6 months. So $50 is going to be a no-brainer to them. So I like the Sorolla belt. And I'll have them use that during waking hours when they know that they're going to be in positions of compromise or in pain. So for long standing, they can wear it underneath their jeans or their work clothes, or they can wear it above it. In other case, I'm trying to figure out what can I do right now to reduce their symptoms so that patient or that athlete now has buy-in to what I'm doing. You need that. If you don't have comparable signs, patients and athletes who are highly motivated, who are middle to the right side of the bell curve, have seen multiple clinicians. They're looking for an excuse not to believe you. And your goal is, I just want to be able to help. I need to figure out which direction to go. So if compression feels good, we're going to go right there and then. How do I immediately reduce your pain? You add the brace. And what I'll do is I'll have you guys buy a brace for your clinic so that you can test people right there and then, because it's very difficult if just using your hands works. They wanna know what the belt feels like, they wanna know what size it is, they have different, I think they have, like, small, medium, large, extra large. It worst case scenario that you guys don't have the funding, you don't have a belt, accessible to you, what you can easily do is do an ACE bandage, that will cost you $2, $3. A double 6 ace bandage, so you can have one that's a little longer in length, minimum 6 inches in height. And what you're going to do with that ace bandage is you're going to wrap that around their waist, compressing that PSIS, and that determines again if compression is helping them. So, do you need a brace? No. Would it be helpful? Absolutely, because now you can have them visually see and feel what that feels like. If you don't, then I would use an ace bandage to help replicate the same thing. If those things work and they need time before they get a belt, or they're not bought into the belt, that's okay. The next thing I'll go down is taping. So flexible taping, something like some type of elastic taping, kinesio tape or kinesiology taping. Doesn't matter to me. My favorite brand is Rock Tape. Has the best adhesive. I've tried them all over the last 15 years, and that one seems to be get me the better outcomes. So I'll tape, and I'll tape into the position that helps them feel what it is I'm trying to do. So compress the PSIS. So I will literally grab the ASIS on the ipsilateral side. I'll apply the tape on the ASIS, and I'll wrap around their pelvis through the PSIS to the contralateral ASIS. And what that does is that compresses that side, and I'll try both sides. I'll try versions of this. And if they love that, that is another sign. Once you do this to somebody who's in pain, man, they think you're like magic. They're like, "Where? How did you know that? How did you?" And that feeling when, and it's a test. I call it the eyebrow test. When I tape somebody and they feel amazing, just watch their eyebrows. They're like, "Oh my gosh, that is amazing. It's what I've been looking for." Now, you as a clinician, obviously, I know what your brain goes. You're like, I don't want to depend on anything. Blah blah blah. I get it. So what you're going to do now is then you can use your long-term delayed movement expert stuff to help get them into the positions that you want. So, but you need initial buy-in to help them comply with what you're talking about. Once you get those eyebrows up, the next stage is how do I maintain that positive eyebrow experience? And so their pain has to be able to reduce. But you and I know that you're not going to have sustained outcomes if you don't change movement, if you don't change mobility, you don't change stability, you don't change any of those components. So this is just a temporary fix, which helps their buy-in. Now you have an opportunity for the long-term things. So for immediate pain, I have we said bracing, taping. All right. So for the stubborn ones, if you've been working with these individuals and you haven't been able to get immediate pain, you've tried the bracing, you've tried the taping, you tried the manual work, you've tried any form of modalities, east, whatever it is that you love to do, maybe do dry needling, and that hasn't worked. All right. The question becomes, what do you do next? For the super complex people who they can't even get to the exercise component because their pain is so high. All right. The next step is pretty classic in care is cortisone injection. A cortisone injection is a purely a diagnostic tool plus a way to reduce their pain while they go on to the next phase. So you'll have to help navigate these conversations and trying to figure out what the next step is for their care. But ultimately, if you haven't been able to get to the exercise stage, or you've been in an exercise stage and they haven't been able to get at least 50% reduction within 8 weeks of working with you, that's a problem, right? So your next stage is, what do I recommend? The worst case to be in is, I don't even know what to do next. That is the worst feeling as a clinician, where you've at least been able to help somebody, like, well, I would work on this, or I would go down this, next stage. But if somebody's had an MRI, they've had an X-ray, they all come out clean, and you haven't been able to reduce your symptoms with your magical hands, your magical movement things. You've done the taping, you've done the bracing, you've done the exercise, you've done the education, you've done the posture assessment, you've done all those things, and the ergonomics still hasn't changed. You have to have things in your arsenal to be able to go to that next level, because these are humans who have pain, and your goal is to get them out of pain and like get them back to the things that they love to do. So for you, the next step is, well, what would I recommend? Now, a cortisone injection would probably be the next step, depending on the primary, or if they have an ortho, or if they have a spine specialist or somebody in their wheelhouse. So you would do a cortisone injection, and that is a great diagnostic, because typically people will have 30 to 50% reduction just instantly. They'll be like, oh my gosh. That tells you you're in the right path, because the fact that it had reduced symptoms told you there was inflammation there, and you've reduced that. So now they can actually explore new ranges. They can work on their thorax and corrective exercises to make the impact. So the way I frame this to athletes is, listen, you're going to get an injection. I think it's the next step for you. We haven't been able to do this here. I'm not saying that what we haven't been doing isn't working. It's just not working at the rate that I would like. And you understand that, because if this was you, all you would want is somebody to explain, like, what is the next step? Because if you're at the end of the road, that's pretty depressing, because there's not a surgical option for, a lot of surgical options for sacroiliac pain. So the question becomes, what am I going to do next? Right. So you can point in that direction. And the way you frame it is, you'd let them know, listen, we're going to have you go down this route. You're going to come back quickly, and within 72 hours, we're going to get you stabilizing that joint again. So all this does is it buys us time to now allow you to move a little bit better, to explore those ranges that you haven't been able to because you were in so much pain. This allows us to buy that time for the next 4 to 6 weeks to build our program to make you more stable, or whatever your preference is. All right, so that's a cortisone injection. They'll typically do, depending on your surgeon, 2 to 3 times a year, to be able to help this individual. If that doesn't help, or if they're not in love with that idea, the other option to do that has worked well for a lot of cases that I've managed, super complex, high-end athletes who are very, very fit and active, is prolotherapy. And Prolo is essentially, if you haven't been exposed to it, Prolo is basically injecting saline at a site within the SIJ joint, where you're basically hardening the unstable components. So whether that's a ligament tear or a sprain, and that ligament it's a little bit more lax than you would like, whether it's post pregnancy or it's somebody who had a hard fall. That's typically the case where that ligament has been stretched. And what they'll do is they'll inject saline to help stabilize that ligament and immobilize the joint. So that has done very, very well, and they'll usually do that in a series. They'll do every 3 to 4 weeks for about 3 months, and depends on protocols, whatever's current and up to date with research at the time. And what you're trying to do, you're trying to find resources for this individual to try and figure out, what do I do next? I mean, if this was me, but where would you go? What would you be doing? And you can't tell me you do exercise all the time. You would be in so much pain. And at some point, it's easier on your end as a clinician because that's what you gravitate towards. Like you think you can fix everything with exercise. And the reality is that you have to be able to reduce pain so that they can do the exercise effectively and make long-term changes as well. So cortisone injection, prolotherapy are fantastic, good options for you. All right. So once you've done the immediate pain, you've gone even through the complex people with either a cortisone injection or prolotherapy. You've tried the bracing, tried the taping, and now they have relief. And now you're trying to figure out, all right, now I'm actually working trying to make long-term changes. So what are you working on? You have to decide, all right, are you working on instability or stiffness? What is it are you trying to do? Are you trying to stabilize a unstable section, or are you trying to loosen up a stiff section? So whatever your preference is, I actually do both. If I have a right PSIS or right iliac or ilium that's too mobile, I'll try and stabilize that side, and I have a left stiff ilium. I'll work on that side and mobilize that so I can have a little bit of balance. It's all in theory, right? And so all you're trying to do is package this so it makes sense. So I'll work on the unstable and stable components or stiff components, and you have to decide which framework you're doing. The one thing I can tell you is, do not just work on the painful region. You need to be working on both, because if one is loose, you have to figure out why that is, and then work on the contralateral side to make sure that you are navigating that as well, so they don't continue to have that reinforced. And so, are you working on the unstable side, or are you working on the stiff side? You're probably going to do both. Then becomes your fun part. This is where you salivate as a clinician. The motor control, right? Like what am I going to do here? All right. So you are 1/5 of the total puzzle that you're going to have to work on. So let me give you what's going to happen next, especially with chronic. So if you look at the strength training pyramid, essentially, if you look at like peak performance, and at the bottom of the pyramid is neuromuscular control. Right above that is muscular endurance. Right above that is hypertrophy. Right above that is strength. Right above that is power. And at the very top of the peak is skill. Now we don't work on skill as a clinician. That's typically up to the technical coach, soccer coach, tennis coach, whatever that is. Do we work on power? Depending on your setting, but you might be working with a strength and conditioning coach, personal trainer who helps with that athlete with those specific things, or whether that's a functional fitness coach or whatever it is. And so we pretty much will not be in that domain, but we will work on the other domains, which is neuromuscular control, endurance, hypertrophy, and strength. So if you have 4 domains to play with, you have to figure out where they are in their season of training. If they're a soccer player, whatever it is, they're typically in the off season if you're working with them with a chronic situation like this. So if we break this down into what you do as a clinician, let's start with neuromuscular control. How long does it take for someone to build good neuromuscular control? 4 to 6 weeks. If that's the case, ultimately, what you have to figure out is, if you are going to be working with, an athlete, and it's going to take you 4 to 6 weeks, you can accurately predict or project how long that person will take to develop the skill, the new motor control learning phases that you're trying to design. So if neuromuscular control is 4 to 6 weeks, your next progression is, okay, once I've got through the 4 to 6 weeks, what's the next step? You're next going to build on muscular endurance, which in neuromuscular control, you might be 15 to 20 reps developing, a good understanding of where the body space is, balance, all those type of things. That took you 4 to 6 weeks. Now, when you develop muscular endurance, that's going to typically take you another 4 to 6 weeks minimum. And what you're going to do is you're going to drop your reps, and you're going to increase your resistance. So you're at the range of 12 to 15 reps. Now they have good control. Now you're trying to build an endurance, the bottom of the pyramid for them. As you develop that for 4 to 6 weeks, let's look at mathematically. If it took you 4 to 6 for neuromuscular control, it took you another 4 to 6 for muscular endurance. You're at 8 to 12 weeks just to set the foundation. Now, if you're working with this athlete and you have an opportunity to take them above and beyond, this is where people say, well, how much better are you going to make me? And if they're approved for, 8, 10, 12, 16 visits, now you have to figure out, well, it's going to take you a few visits to get them out of pain. Where do you want to keep and stash some of your visits so that you can, push them out for as long as they need? Or maybe you work in a cash-based setting, and maybe this person is trying to, figure out how can I maximize. Maybe they don't have all the cash or the funds that they need to be able to do the course of care. How do you project and help somebody make better decisions? Maybe you only need a couple sessions on the pain management side. Then you're building programs, and you only see them monthly, so they can actually move on to next phases without having to rely on your hands and everything else. You become a person who is now helping manage their care. You're working now on strength conditioning. You've now developed 8 to 12 weeks of neuromuscular control plus muscular endurance. The next step is, what's the next phase? Depending on their sport and what their goal is. These people might have atrophy. They might not have like a good set of glutes or quads or whatever it is. So you're going to work on hypertrophy before you work on strength. So what you're going to do is you're going to drop your reps to 8 to 12. You're going to increase your resistance. You're going to increase your tempo. So now you've developed neuromuscular control for 4 to 6 weeks, muscular endurance for 4 to 6 weeks, and now you're doing hypertrophy another 4 to 6 weeks. Once you develop that hypertrophy, you have a great base. Now you can develop strength because now you have the size, you have the control. Now you can do another 4 to 6 weeks of pure strengthening. And now you can drop that 5 to 8 reps, increase your resistance. And now you have somebody who has glutes of steel. One side is now more stable, the other side is loose. You've been working on this, you have a great mechanics, they have good single leg balance. They've been able to manage this all while you've been able to decrease their pain immediately, or you were able to do that early with either they got an injection, or you were to do that with tape, or whatever your magical hands were able to do. And you and I know that if you're going to work with a chronic case, this might take a little longer than you anticipate. And the only way to get these people out of pain is develop a better foundation for themselves. And if that's the case, it's not going to just be 8 sessions. You have to be able to project that and say that confidently. Where I see most PTs struggle is that they don't know, they don't feel comfortable saying, well, this is going to take you 6 weeks, it's going to take you 8 weeks, it's going to take you 12 weeks. Why? You don't have the confidence. And so if you really look at it on paper, you actually have all the information in front of you. In theory, it'll take you 4 to 6 weeks for neuromuscular control, 4 to 6 for endurance, 4 to 6 for hypertrophy, 4 to 6 for strength, 4 to 6 for power. So that's a 3 to 6 month project. And for most of you, you know that. So the question is, why don't you relay that to the patient? I don't understand why you can't say that. It's because you don't want to be wrong. So what do? You just don't, you avoid the conversation and say, let's just go week by week. And you still don't map out and plan out any of their progressions. You just go week by week. Well, of course, they're not going to get better. And that's why they stay stuck inside your clinic and you don't get the outcomes. Now, that might work with somebody who's like a fresh chronic, pain who just entered remodeling, and you can make changes and they're going to get better naturally. All you're maybe doing is expediting. But if you really get these people who have been to numerous clinicians, they've been in a year or 2 years of pain, and they are looking for something different, your old school way, traditional way of doing things is not going to work. And that's probably where you get stuck, especially with chronic, recurrent, stubborn SIJ pain, sacroiliac pain. And it's because you're missing pieces of the elements. And if you're looking for, what other tools can you add to your toolbox? What is that you're missing inside your clinical care? This is a big component. It's basically the shell around everything that you do, meaning the framework. So if you can say, what corrective exercise you're going to do. Like you've spent a lot of your life trying to figure out the best exercise for low back pain, when it's irrelevant if you don't understand how long this is going to take and which phase that they're in and which phase you are in. Most of the time you obsess over 10 to 15 repetitions, slow and controlled, you're basically living in a neuromuscular control phase. That's why people don't get the outcomes they want because they haven't moved on to anything else besides neuromuscular control. They haven't gone to endurance. They haven't gone to hypertrophy. They haven't gone to strength. That's why you can't create long-term outcomes. Your hands, your manual work, and your like sexy exercise will get you so far. And in these chronic people, it doesn't work because that usually fades out and they figure it out right around the fifth through eighth session. They're like, I'm just not getting better. Here's the secret sauce. Most of them, if they don't have 50% improvement by week 8, they're gone. They won't be back. They're going to be non-compliant because you failed to identify where the problem was going to happen. And if you haven't taken any of my courses in the past, I project about 10 to 15% improvement on a weekly basis with chronic pain. Meaning, if you have somebody, hey, how close are you to 100%, like your version of 100%, like in your daily life? And how close are you back to exercising? If they say 100%, you've done your job. So if you have somebody who's fresh on your schedule and you're they want to get back to running. If running is 100% and currently you're at 0%, every single week they see you, they should have at least some form of 10 to 15% improvement. And the reason I've seen a lot of physical therapists say they don't like asking this question is because they don't want to know that what they are doing is not working and they don't want to have that confrontation and awareness right there. They'd rather just go around the subject and say, well, let's just keep trying. Let's just keep trying. The best thing you can do is ask, what percent improvement have you been since starting with us? And you'll say like 30 or 40%. That's beautiful. By week 4, you should be at that 50%. By week 8, you should be at 90 or 100%. If you're not there by week 8 and you're at 50%, that's still a problem. Most people don't see the value in what you do. Why? Because you haven't been able to get the outcome in the timeline that they would expect. So the only thing you could change there is change the expectations of what that timeline is going to be. And now you can work on programming, you can work on strength conditioning. So now you can say, hey, listen, I can get you out of pain within the next 8 to 10 weeks because I know in the first 4 weeks I'm going to do neuromuscular control, then I'm going to do muscular endurance. We'll work on, reducing your pain, getting you tape, braced up, all those other things. But where the real magic is going to happen is in developing your strength and conditioning with hypertrophy and strength, which will take another 3 months. Now, that'll typically be outside of your patient care visits or approved by your insurance. Now, I'll get you about 50 to 60% better in the next 8 weeks because it's been going on for so long. But where I can really help is designing something for you afterwards. Now, you won't have to come see me every single week. The only challenge with that is you're only going to have to come see me monthly. I'm going to design a program for you. I'm going to build out strength programs for you for the first phase, which is going to be 6 to 8 weeks or 6 weeks of hypertrophy. And then you'll come back, we'll check in. I'll design a new one for you to get you strong again. And what that'll allow you to do is make gains, not be dependent on me, but consult with me to figure out what the next step is. Now you've gotten somebody who's been chronic, who hasn't had any help in the past, no one to help them guide because they were looking for immediate changes in pain. And you and I both know that's not possible when something has been a year or 2 years in chronic pain. There has to be a change. But what people are looking for, just as you are, is they're looking for immediate gratification. And if you can't produce immediate gratification to just at least hit that and allow them to see how you can change their life, if you are only working on delayed treatment strategies, motor control, movement, exercise, and you don't have a lot of time or resources to get their pain down immediately, manual therapy, taping, bracing, all of the above, dry needling, whatever your magic is, and you are by principle, like this is the thing I hear from PTs. Well, I don't want them to be dependent on me, so I don't want to do manual work on them. So I'm just going to work on exercise. I know that's the real root of their source. The problem is that's why they don't come back to see you because you haven't proven the value that you can actually do it. You're over here looking at the delayed gratification of what's going to happen. This person's looking for immediate. So you have two people with different expectations. This one's saying, you know what, we're going to get better in 6 to 8 weeks. This patient's like, yeah, but I'm wasting 2 hours of my life to come see you, half hour to drive here and back, plus an hour of patient care. That's 2 hours of my life times 8 visits. That's 16 visits. If you haven't been able to prove that, why should I keep going and hoping for something to change? And you as a clinician have to see that. So you have to get their immediate pain down and while also designing the plan for the delayed treatment plan. So the big thing I wanted to give you is ultimately, yes, I want you to have a better shell or framework inside how you approach an athlete. But more than anything else, it's educating yourself and the patient on what's an expected return to 100%. And you have to be able to comfortably project that. And if you can't, that's a lack of confidence because you don't have the skills, and that has to hit you in the face. Why can't you project how well somebody's going to get in 4, 6, 8, 12, 16, 24 weeks? You know what the stages of improvement should be from a programming perspective, from a neuromuscular control perspective, from a strength and conditioning perspective. So why don't you align that when you would reduce their pain? Why can't you overlap immediate pain reduction with long-term strengthening and give them a timeline? For some people, that's all they want to hear is, how long is this going to take me? So I have an understanding. Most people are just looking for a solution. You're trying to fix the problem, they're looking for a solution. Two different worlds they're living in. You're trying to fix a problem at hip abduction, tibial lateral rotation, Trendelenburg. Those are problems. They're looking for a solution to their problems. What is it that they're not seeing or doing that they need to change in their life and that you can help them do in the next 4 to 6 months and make it a long term change, not just an immediate thing to fix the short term problem that they have bilateral pronation or, knee varus or whatever it is. Those are easy fixes. The long term fix is, what do I need to do to conquer this pain for good? And if you are equally invested in their health, that's the approach that you need to take. And that takes a lot of patient education, not patient education on how to sit better and do those things. It's, how do you solve this permanently? What is it that you need to do from a daily perspective? What are they doing on a daily basis? Is it their car? Is it their sitting? Is their posture? Is their standing posture? Is their flexibility? Is their hip mobility? Is it all these other things? And what's the timeline to get that better in? And if it's a strength and conditioning issue, if it's a tightness issue, you adapt that and include that inside their exercise regimen. If they're in the middle of the bell curve to the right side of the bell curve, they need these guidelines. You are an active individual and you would appreciate this as well. The challenge you have is developing the confidence and skill set to deliver on this. So, if you frame your session of a chronic, recurrent, stubborn sacroiliac joint pain case with a person in the middle to the right side of the bell curve, it's learning how to have that conversation, being able to program from somebody and taking them beyond their muscular control, because that's where you're the expert, but you're scared to add the next element, which is add more load, decrease your or increase your tempo, then move them over to strength, increase your load, add more load so they can tolerate and be able to sustain those things. And that's where you're hesitant. You have to be able to get them there. That's not going to happen overnight. You know, it goes in 4 to 6 week blocks. So project that all the way out, being able to change your pain immediately. This puts you in a good position. But if you don't outline this to the patient from the beginning and throughout, there's no buy-in, and that's where you're going to struggle. So those who were asking for this on the academy call last week, yeah, no, this is, I'm getting my, if you ask why are you doing more of these patient cases, is because I'm getting ready. If you guys haven't taken my sports PT Kickstarter course, there's a lot of patient cases in here, and I love my Kickstarter course. I love delivering it because it changes the way that PTs approach patients. It's the thing that change. That's why people attend the Kickstarter. It's because they're like, I'm missing something, and you're usually looking for more Therex. That's like, I'm going to go to a course because I'm going to use more Therex. I'm going to go to a course because I'm going to use more hands-on skills. And I'm telling you right now, you're missing out. Those are like the least of the problems. The biggest problem is how you approach the athlete. And I just recently had somebody who's done a residency take the Kickstarter, and they said, it filled in gaps that I didn't get in my residency. And that's a huge honor. If you think about this, I mean, residency they're credentialed huge challenges that they've had to overcome to create something structured to be able to benefit people. And I think that if you are looking for a residency, I think that's great. This course, my Kickstarter course, is perfect because it fills the gaps that a residency doesn't give you. And they mentioned, I honestly, I would have preferred to take the course before I did my residency, and that's a huge honor. And for those of you who are students, new grads, established clinicians looking for more Therex or more hands-on skills, and you know that there's something missing, the Kickstarter course is for you. It's patient-centered. It's about navigating the real root of what you're not seeing and what you're not using inside your own approach to seeing patients and athletes. In there, you're going to be doing injury prevention programs, you're going to be doing strength conditioning programs, and I will ask you to do patient cases on how you would navigate, and you're not even allowed to do Therex. And that will take all of your arsenal away. So, how do you fix people's pain without Therex? I will help you solve that. And for those of you who are skeptical and think it's not possible, or that's like that's not even a thing, or that's what we do as clinicians. I think that's absolute crap. And I think that if you're looking for more Therex, this course is definitely not for you. If you're looking for something different than Therex, and you're looking to add more skills so you can develop the confidence in managing patient cases without relying on Therex, the Sports PT Kickstarter is perfect for you. So I'm hosting that in less than a month, January 10th of 2024, whenever you listen to this. And that's when it starts. So it's an 8-week online mentorship course. For those of you interested, go over to drchrisgarcia.com/Kickstarter. For those of you who've taken it or any of my courses and you're like, I'm fed up, I'm finally frustrated with where I'm at, and I've taken all the courses and I haven't got better, and I'm looking for something different, come over to the dark side of my academy. That's where we meet monthly. We go over patient cases. We figure out where you're stuck, what you're missing. Do you really need the strength programs? Do you really need a residency? Is CSCS for you right now? What do you need to do to get more athletes on your schedule? Do you have to create more wellness programs? Where are you getting stuck? Is it post-surgical cases? In either case, it's going through dialogue to figure out how to get unstuck inside your clinic, regardless if you have a mentor, if you've never had a mentor, you're sick and tired of doing it by yourself. Ultimately, it's a place where you can grow, and it gives you an opportunity to ask questions that you're not judged. Nobody cares. Everyone's struggling through the same things. What is it that you're not seeing? Are you fed up with your clinic? Are you fed up with how things are going? How you're fed up with insurance? You're fed up. There's just so many layers. And if you are interested in getting into a community that's different and is about sports PTs thriving and not just seeing more patients, then this is the perfect place for you. So if you're interested, you can go over to drchrisgarcia.com/academy and submit your application. I'd love to have you in the group. We have a great group at the moment, great cohort. And I'm excited to continue to help everybody thrive. So there you have it, SIJ pain and easy ways to do it, clinical pearls and rehab strategies, truly for the sports PT, not just for the ortho clinician. So I hope that helps. I hope you guys are doing amazing. I will see you guys on next episode. Take care.